live by Dr. Pat, leading innovation in fertility excellence.
You know, when you look at the landscape of modern medicine, there's this strange paradox.
Oh, there really is. It can be incredibly jarring.
Right. Because, I mean, we can edit genes now, we can print 3D organs, and yet for some of the most common conditions affecting you and millions of others, the default treatments can still feel incredibly archaic.
Yeah, that's exactly the word for it. Archaic.
It's basically like using a sledgehammer to fix a watch. But for 20 to 40% of women over 30, that sledgehammer has historically been the only guarantee for relief from uterine fibroids.
It's true. We tend to rely on these extreme structural interventions for functional problems. And, uterine fibroids or myomas are technically benign tumors.
But calling them benign kind of downplays it, doesn't it?
It completely downplays the reality of living with them.
Yeah.
Because for about a third of the women who develop these, the clinical burden is just massive.
Yeah, the symptoms are intense.
Very. You are looking at hypermenorrhea, which is menstrual bleeding so heavy it routinely leads to severe anemia and chronic fatigue.
Right, just completely draining.
Exactly. Then there is dysmenorrhea, which is debilitating pelvic pain, along with pain during intercourse. And some of these fibroids grow large enough to actually press on the bladder or the bowel.
Wow. So it's structural pressure, too.
Yeah, it creates a constant heavy pressure in the pelvis that entirely disrupts a person's day-to-day existence.
And historically, if a patient brought those symptoms to a doctor, the solutions were pretty bleak. I mean, the gold standard for guaranteed symptom relief for decades was literally a hysterectomy.
Right, complete surgical removal of the uterus.
Which is huge. And for a patient who wanted to preserve her uterus, the alternative was a myomectomy.
Which is no walk in the park either.
No, not at all. That often meant complex, invasive abdominal surgery with a long, painful recovery time. So if you were seeking relief without losing an organ or, spending weeks out of commission, your options were terrible.
It was essentially a binary choice. Endure the symptoms or endure major surgery. Because fibroids are monoclonal tumors, right? They arise from the myometrial muscle of the uterus, and they develop their own dedicated blood supply.
So they're really entrenched in there.
Deeply entrenched. Cutting them out while leaving the highly vascular uterus intact is technically challenging. It carries significant bleeding risks.
Oh, I see.
So removing the entire organ was simply the path of least resistance for the surgeon, even if it meant ignoring the patient's long-term health or reproductive desires.
Well, our mission for this deep dive is to look at how that paradigm is finally shifting. Because we have a stack of recent clinical studies, medical device documentation, and case reports exploring this innovative uterus-preserving procedure.
It's a game changer, really.
It is. It's called transvaginal radiofrequency ablation, or TRFA, utilizing specialized equipment like the MitoBlade system. Okay, let's unpack this. Destroying a tumor deep inside a specialized organ without cutting the patient open sounds like a logistical nightmare.
It sounds like science fiction, right? But to understand why this is replacing invasive surgery in so many cases, we first have to look at the ingenious engineering behind the procedure.
Right, because they aren't actually pulling it out.
Exactly. The goal of TRFA isn't to physically extract the fibroid at all. The goal is to destroy it in place using targeted thermal energy.
So, based on the MyoBlade system documentation, the physician uses a transvaginal ultrasound probe to visualize the uterus.
Correct.
And attached to this probe is something called a V-guide, which is a non-conductive needle guide. This setup allows the doctor to insert a very specific 17-gauge electrode needle straight through the vaginal wall and directly into the center of the fibroid.
Yeah, and precision is the entire foundation of the procedure here. The V-guide keeps the needle perfectly parallel to the ultrasound field of view.
So they can see exactly where it's going.
Right. The physician isn't operating blind or just guessing the trajectory. They are watching the needle advance on a screen in real time.
That's amazing.
And the protocol mandates a strict 1 centimeter safety zone. The active tip of the electrode must remain at least 1 centimeter away from the outer edge of the fibroid.
Just to make sure they don't accidentally hit anything else.
Exactly. To ensure no healthy uterine tissue or surrounding organs are inadvertently heated.
But the physics of injecting raw heat into the body seems risky to me, because the Mygen V1000 generator pumps 100 watts of high-frequency alternating current, I think it's 480 kilohertz, into this needle.
That's right.
And it heats the tissue to somewhere between 60 and 80 degrees Celsius. Trying to contain that heat to just the tumor seems nearly impossible. Is this like using a high-tech meat thermometer that cooks a meatball from the exact center outward without ever searing the outside?
That analogy actually captures the mechanism perfectly. It is cooking the center of the meatball while leaving the exterior untouched.
But how?
Well, the reason the heat doesn't just indiscriminately spread and destroy healthy tissue is due to a deliberate contradiction in the equipment itself.
A contradiction.
Yeah. You have this generator delivering intense high-frequency electrical current to heat the tissue, but paired with it is the RP300 cooling pump.
Wait, so pumping cold fluid into a needle that is simultaneously trying to heat up the surrounding tissue? That seems like pressing the gas and the brake at the same time.
It really sounds counterproductive, but it solves a critical problem in thermal ablation called carbonization.
Okay, what is that?
So if a physician just stuck a hot metal needle into biological tissue, the cells immediately in contact with the metal would instantly char and turn to carbon.
Oh, like burning a steak on a hot grill.
Exactly. And carbon happens to be a fantastic insulator.
Ah, I see where this is going.
Right. Once that charred layer forms around the needle, the heat can no longer radiate outward into the rest of the tumor. You would end up with a tiny burned cylinder of tissue right around the metal, and the vast majority of the fibroid would remain perfectly healthy.
And it would just continue to grow.
Exactly.
So the cold saline circulating inside the electrode keeps the tissue directly touching the needle from burning and turning to carbon,
Yes.
which forces the radiofrequency energy to travel further out into the surrounding tumor tissue before it converts to heat.
You've got it. By maintaining a cool contact area, the system creates a much wider, safer, and more uniform ablation zone. The objective isn't to vaporize the tumor.
It's just to heat it up.
Right, the goal is to heat about 70 to 80% of the fibroid mass to that 60 to 80 degree threshold.
And at that specific temperature, the tissue undergoes what they call coagulative necrosis, right?
Correct.
The proteins in the fibroid cells denature, the cells die, and the blood vessels feeding the tumor are destroyed. The tumor experiences localized ischemia,
Which is a total loss of blood supply.
and that halts the fibroid's growth immediately.
Yes, dead in its tracks.
And because the procedure only targets 70 to 80% of the mass, that 1 centimeter outer shell acts as a buffer, so it ensures the healthy myometrium of the uterus remains untouched.
Exactly. The engineering guarantees we don't burn healthy tissue. But dealing with the aftermath of that heat is just as important as generating it.
Yeah, because leaving a dead necrotic mass inside the uterus sounds like it could cause its own set of severe problems. I mean, engineering is great on paper, but how the human body actually responds to having its tumors cooked from the inside is what determines if this is a viable treatment.
That's the real test. And to evaluate the biological response, we have to look at a robust retrospective observational study published in the Journal of Clinical Medicine.
Ah, the MDPI study.
Yes. This study tracked 121 premenopausal women with a mean age of about 41 who underwent this exact outpatient TRFA procedure.
And the volume reduction numbers from that study are surprisingly high. Like at 6 months, the fibroids had shrunk by an average of about 58%.
Which is significant.
Very. And by 24 months, they had shrunk by nearly 61%. But here's my thing. Shrinking a fibroid by 60 to 90% over a year sounds great on an MRI, but does the patient actually feel 60% better? What is the day-to-day reality for the listener experiencing these symptoms?
It's a fair question. If the tumor is still there, just smaller and dead, it's hard to imagine they are entirely getting their lives back.
Exactly.
But the data strongly supports that they are getting their lives back because the reduction isn't just cosmetic. After the coagulative necrosis occurs, the dead tissue is slowly dissolved and reabsorbed by the body's immune system over time.
Okay.
And as that mass decreases, the physical pressure comes off the surrounding organs, relieving the pelvic pain and the bladder issues. But more importantly, the abnormal bleeding stops.
Because those blood vessels are gone.
Right, the aberrant blood vessels that were feeding the fibroid have been permanently destroyed. The study actually quantified this symptom relief using the Uterine Fibroid Symptom and Quality of Life Questionnaire, or UFSQOL.
Yeah, and the baseline for these women was severe. I saw they had an average starting score of 30.9 time.
That indicates a highly disruptive symptom burden. But at 24 months post-procedure, that average score had dropped to 14.97.
That is a huge drop.
It represents a massive, sustained improvement. The symptoms didn't just temporarily fade, they stayed improved 2 years out. In fact, at that 24-month mark, nearly 69% of the patients required absolutely no further treatment or medication for their fibroids.
That's incredible. And the recovery time presents a sharp contrast to traditional surgery, too, because these procedures were fully outpatient.
Yes.
I mean, they required general anesthesia, but there were no incisions. The study found that patients required an average of only 2.87 days of mild over-the-counter painkillers.
Less than 3 days of Tylenol or Advil.
Right, and they only needed an average of 3.34 days of sick leave before returning to their normal lives.
That recovery profile is transformative. Think about a traditional hysterectomy. That often requires a hospital stay, up to 6 weeks of at-home recovery, the use of heavy narcotics, and just significant disruption to a person's livelihood and family life.
Not to mention the long-term stuff.
Right. There are long-term implications with a hysterectomy. Pelvic floor changes, and if the ovaries are removed, surgical menopause.
Yeah, that's intense.
Even a myomectomy, while preserving the uterus, still involves significant abdominal healing and scarring. So achieving surgical-level symptom relief in under 4 days with no incisions is a major advancement.
It totally makes sense why 96.61% of the patients in the study reported being satisfied or very satisfied with the procedure.
Absolutely.
But, whenever clinical data presents a 96% satisfaction rate alongside a 3-day recovery, I start looking for the catch. And diving deeper into the statistics of this 2-year observational study, there is a glaring nuance regarding reinterventions that demands closer scrutiny. Because the study explicitly notes a 24.79% reintervention rate over 2 years.
Yeah, that figure definitely stands out.
Wait, the study says there was a 24.79% reintervention rate. If I'm a patient considering this, a 1 in 4 chance of needing another surgery sounds like a massive failure rate. Why is this considered successful?
What's fascinating here is how the researchers categorized a reintervention. Because breaking down that 24.79% reveals a much more strategic approach to patient care.
What do you mean?
Well, it turns out that 44.4% of those hysteroscopic reinterventions were actually pre-planned by the doctors before the first procedure even took place.
They planned. Planning to do 2 surgeries from the start seems highly unusual.
It does, but it comes down to the location of certain fibroids, specifically submucosal fibroids.
Which are the ones that bulge directly into the uterine cavity.
Exactly. They can be incredibly tricky and dangerous to remove surgically because they are heavily vascularized. If a surgeon simply goes in and tries to cut out a large, live submucosal fibroid, the risk of severe, life-threatening hemorrhage is very high.
Oh, wow. So the doctors use the radiofrequency ablation as a preemptive strike to mitigate that bleeding risk.
Bingo. It is a deliberate sequential therapy. The physicians utilize TRFA first, not to cure the patient with the heat alone, but to kill the fibroid's blood supply and cause it to shrink over a few months.
And then what?
Once the fibroid was smaller and completely devascularized, meaning it wouldn't bleed excessively, they went back in with a simple hysteroscopy to easily and safely remove the dead tissue.
Oh, so the TRFA wasn't failing those cases. It was doing exactly what it was designed to do.
Exactly.
It turned a high-risk, potentially hemorrhagic surgery into a low-risk routine removal.
Yes. So removing those pre-planned sequential treatments from the data provides a much clearer picture of the actual efficacy. The unplanned reintervention rate, which is the true failure rate, where the ablation didn't provide enough relief and the patient unexpectedly needed a myomectomy or hysterectomy later, that drops down to 18.19%.
Ah, okay.
And while not zero, an 18% failure rate is highly competitive with other uterus-preserving treatments on the market.
That context completely changes the interpretation of the data. And, since the primary goal for many patients opting for TRFA over a hysterectomy is preserving the uterus, the most obvious follow-up question is about fertility.
Of course.
Because subjecting an organ to 80-degree thermal ablation could theoretically compromise its ability to carry a child.
It's a very valid concern, and fertility post-ablation is an area of intense ongoing research. The source material from Weill Cornell Medicine explicitly cautions that because this technique was only FDA approved relatively recently, there's limited long-term data on pregnancy outcomes.
Right, they need more time.
Exactly. The medical community is very careful to state that robust, multi-decade information is still being collected and analyzed.
But the 2-year observational study did manage to capture some concrete data on this, right? I mean, they didn't explicitly design the study to test for fertility, but they tracked the outcomes for the patients who did conceive.
They did.
And over the course of their tracking, they recorded 22 post-TRFA pregnancies.
And the outcomes for those 22 pregnancies were highly encouraging.
Yeah, the numbers look great. Out of those cases, 81.82% resulted in full-term deliveries.
That's fantastic.
And the cesarean rate was surprisingly low at just 27.78%. Plus, the median time from the ablation procedure to conception was only 11.5 months.
Less than a year.
Yeah. This data clearly proves the uterus remains highly functional and capable of safely carrying a child to term shortly after having its tumors thermally destroyed.
It really suggests that the 1 centimeter safety margin is effective, and that the coagulative necrosis within the tumor doesn't compromise the structural integrity or the elasticity of the surrounding myometrium during the extreme stretching of pregnancy.
That's wild to think about.
But, any patient prioritizing future fertility absolutely needs to have a nuanced conversation with their specialist. The global data set, while promising, is still growing.
For sure. So we've established that the technology uses internal cooling to safely ablate the tissue. The clinical relief is significant, the recovery is incredibly fast, and the uterus survives the ordeal intact.
Correct.
And under normal circumstances, the dead fibroid cells are just slowly dissolved by macrophages and absorbed by the body over time.
Yes, that gradual absorption is the standard expected biological mechanism following any thermal ablation.
But the human body doesn't always follow the standard mechanism.
No, it certainly doesn't.
Occasionally, the body takes a far more dramatic route to rid itself of the dead tumor.
Oh, this case.
Yeah, right. There is a fascinating case report published in preprints.org that reads almost like a medical mystery. They detail the case of a 41-year-old woman who initially presented with heavy bleeding and pelvic pain.
Yeah.
An ultrasound revealed a 5-centimeter fibroid. She underwent the standard TRFA procedure, and the surgery was completely routine.
Right. No complications were noted during the operation, and she was discharged home the same day, just like normal.
Exactly. But 1 month later, she returned for a follow-up. Her pelvic pain had improved, and the ultrasound showed the fibroid had shrunk by about 1 centimeter. That is standard progress.
Totally standard.
However, her heavy bleeding hadn't stopped. And then, 2 months after the procedure, the situation escalated. She returned to the clinic complaining of excessive spotting, a foul-smelling vaginal discharge, and heavy bleeding.
And at that 2-month mark, presenting with those specific symptoms, the clinical assumption might be a post-operative infection. Or perhaps the ablation failed entirely and the fibroid was causing acute, worsening issues.
Right, you assume the worst. But the doctors performed another ultrasound, and they found something completely unexpected. The fibroid hadn't just shrunk in place. It had completely migrated.
Wow.
The entire 5-centimeter dead tumor had detached from the uterine wall and migrated down into the cervical canal, hanging on by a single vascular pedicle. The body was physically pushing the dead fibroid out through the vagina.
It's just an incredible biological response because the uterus is, at its core, a muscular organ designed to expel foreign bodies. That's the fundamental mechanism of menstruation and childbirth.
Right.
So when the thermal energy killed the fibroid and severed its primary connection to the myometrium, the uterus recognized the necrotic mass as dead tissue, treated it as a foreign object, and initiated natural contractions to expel it.
And the medical team took her into the operating room, and under general anesthesia, they simply removed the expelled fibroid vaginally. The whole procedure took 10 minutes. Yeah, there were no abdominal incisions, no complex dissection required to cut the tumor out of the uterine wall. She was discharged in good health without any further complications.
This raises an important question that is currently heavily debated in the medical community.
Oh, I bet.
Is this transvaginal expulsion a complication, or is it a massive therapeutic success?
Well, the report mentions this expulsion phenomenon only happens in roughly 1 to 1.5% of radiofrequency ablation cases. It is exceedingly rare.
Right, and classifying it as a complication makes sense from a clinical management perspective. It causes unexpected heavy bleeding, there's a very real risk of severe infection, which explains the foul-smelling discharge the patient experienced, and it requires the patient to undergo a second, unplanned surgical procedure under general anesthesia to safely remove the mass.
Yeah, that sounds like a complication, but looking at it from the patient's long-term outcome, the tumor is 100% eliminated from the body. It isn't just shrunk by 60% and left to slowly dissolve over 2 years. It is completely gone.
Gone.
And that total eradication was achieved without a surgeon ever having to cut through the abdominal wall or dig into the healthy uterine muscle.
Exactly. And the authors of the case study explicitly state that in this specific instance, they considered the expulsion highly beneficial because the removal was seamless and the fibroid was entirely eradicated.
I can see why.
If the infection risk is proactively managed and the patient has access to prompt medical care, the end result of expulsion is arguably better than the standard multi-year absorption process.
It really highlights how dynamic the human body's healing mechanisms can be. Applying a precise amount of heat triggers the body to take over, sometimes in unpredictable ways that ultimately solve the structural problem without requiring a surgical sledgehammer.
It really does.
So what does this all mean when we zoom out and look at the whole picture? Transvaginal radiofrequency ablation represents a massive leap forward for women's healthcare. For decades, the default answer to the heavy bleeding and severe pain caused by fibroids was to simply remove the entire uterus. But now, using ultrasound guidance paired with internal cooling pumps, physicians can precisely target and thermally destroy these tumors on an outpatient basis. It preserves the organ, drastically cuts down recovery time from 6 weeks to mere days, and provides a dramatic, sustained improvement in patients' quality of life.
And if we connect this to the bigger picture, it is a profound shift in gynecological philosophy, moving away from radical structural removal and toward targeted functional restoration.
Before we wrap up this deep dive, that 1% edge case of the transvaginal expulsion leaves us with a lot to consider regarding the future of this technology.
It leaves you with a truly provocative concept to ponder. If we know that the human body can occasionally be prompted by targeted thermal necrosis to completely detach and safely expel a benign tumor all on its own, could future non-invasive medical tech be designed to do this on purpose?
That would be wild.
Right. Instead of just aiming to shrink fibroids and wait for immune absorption, researchers might one day figure out the exact thermal or biological triggers needed to intentionally activate this natural expulsion mechanism every single time.
Wow.
It forces us to wonder if what the medical community currently classifies as a rare 1% complication might actually be the hidden blueprint for the ultimate incision-free biological cure.
Leading innovation, fertility, excellence. Live by Dr. Pat. Leading innovation in fertility excellence.